Hello everyone, I am Dr. Jyoti Verma. In this class, we will be discussing two anesthesia drugs, two most important anesthesia drugs, Propofol and Ketamine. We will discuss both of them in a particular format. The format is Kappa, Dorset, and Dame. So we will discuss one by one. We will discuss both of the drugs in the same format one by one. So first we will discuss Propofol. If we talk about Propofol, the chemical composition of Propofol is this. It includes 1% Propofol, that is 10 mg per ml Propofol. We have 10% soybean oil, which provides oil phase to the composition. Then 1.2% purified egg phospholipid, which acts as an emulsifier. E for egg, E for emulsifier. That way you can remember. Glycerol is for providing tonicity, which is 2.25%. Then there is sodium hydroxide, which maintains the pH of the composition. We have bacteriostatic agents as well, EDTA and sodium metabisulfite, or EDTA or sodium metabisulfite. They act as bacteriostatic. This composition promotes bacterial growth and increases plasma triglyceride levels. The chemical formula of Propofol is 2,6-diisopropyl phenol, and the structure is this. There is phenol with two chains at 2 and 6 positions. The pH is 7, pKa is 11. The composition is stable at room temperature, and it is can be diluted with 5% dextrose in water. So this is class of drug in use. Class of drug is induction agent. Chemical composition is this. Chemical structure is this, and formula is this, 2,6-diisopropyl phenol. Talking about uses, Propofol is used as an induction agent. It is used as a sedation in monitored anesthesia care. It is used as an antiemetic as well. The dose is 10 to 20 milligram IV, which can be repeated every 5 to 10 minutes. It has antipruritic effects as well. The dose is 10 mg IV. Propofol is also used as an anticonvulsant. Dose is more than 1 mg per kg IV. It helps in bronchodilation, that is attenuation of bronchoconstriction. If we have to avoid inhalational agents and use TIVA, Propofol is used in TIVA, and it is also used in targeted controlled infusion. So these are the uses. Talking about preparations available are Ampofol, Aquavan, Cyclodextrin, Aquafol, and Deprivan. Mechanism of action of Propofol. Propofol acts on GABA receptors, Propofol acts on glycine receptors, and there is minimal effect on NMDA receptor. It is NMDA antagonist as well. So what happens is it activates GABA receptors at cortex and hippocampal area. Activation leads to increased chloride conductance, which increased chloride conductance hyperpolarizes the membrane. Hyperpolarization of the postsynaptic membrane leads to functional inhibition of that membrane. So this leads to inhibition of postsynaptic membrane. So this is the mechanism of action of Propofol. It acts on GABA receptors, activates GABA receptors, increases chloride conductance, leading to hyperpolarization of postsynaptic membrane, leading to functional inhibition of postsynaptic neuron. It also acts on glycine receptor, and there is minimal action on NMDA receptors, leading it is NMDA antagonist. So after mechanism of action is the dose of the drug. So induction dose of Propofol is 1 to 2.5 mg per kg IV over 15 seconds. So induction agent, if the case is pediatric, the dose is increased due to increased volume of distribution. If the patient is elderly, the dose is decreased due to decreased volume of distribution. So dose is adjusted in this range, and it is also adjusted according to loss of verbal response. We talk to the patient continuously while giving propofol, and as the loss of verbal response is achieved, we can stop giving the drug. Then the sedation dose is, loading dose is 25 to 75 micrograms per kg per minute IV, and maintenance is 50 to 150 micrograms per kg per minute IV with nitrous oxide and or opioids. So this is about dosage. Talking about onset of action, onset is one arm brain circulation, that is 11 to 13 seconds, quite fast. Duration of hypnosis is 5 to 10 minutes only. Routes of administration is IV only. Then side effects, the patient can experience allergic reactions due to phenol group or the 2,6-diisopropyl side chains. Propofol infusion syndrome can occur in ICU settings due to prolonged infusion of propofol. Propofol has proconvulsant effects as well. We have earlier studied that propofol is used as an anticonvulsant, but it is proconvulsant as well, quite contrasting. Propofol has abusive nature. It increases dopamine. We will study in ahead. We will study about how it is abusive. Then propofol composition promotes bacterial growth, and it has to be discarded within 6 hours. After 6 hours, pain on injection is experienced by patients when propofol is given. So we prefer giving it with larger vein. It increases triglyceride levels, may cause pulmonary embolism due to mixing with lignocaine, and may cause infection due to propensity of bacterial growth. Propofol provides more of a sedative state, that is calm state, as compared to hypnotic or sleep-like state. Talking about everything else, propofol infusion syndrome is seen in ICU settings when the dose used is more than 4 mg per kg per hour for more than 48 hours. So what is a triad seen? Bradycardia, lactic or metabolic acidosis, rhabdomyolysis. There will be seen hyperlipidemia or fatty liver. So what we have to do is we have to discontinue the propofol infusion, and if there is bradycardia, we have to treat it with ADR. Propofol crosses the placenta in a pregnant female, and it comes out as well. So it can be given in pregnant females. Just for the completion purpose, phosphopropofol is a prodrug which gets converted into propofol in the body. It is water soluble. The side effect of phosphopropofol is perineal burning sensation, which is due to formation of formaldehyde. Contraindications of propofol is, these are relative contraindications. Hypovolemia, if or a patient may have grand mal seizures. So hypovolemia, it causes decrease in systolic BP, diastolic BP, decrease in cardiac output. So in order to avoid this, we can correct hypovolemia and then use propofol. And propofol provides a sense of well-being by increasing dopamine concentration in nucleus accumbens. That is why abusive nature is seen. Propofol has tolerance effect as well. And there is an interaction of propofol with midazolam. Propofol increases the concentration of midazolam in the blood, and vice versa. Midazolam also increases the concentration of propofol in the blood. So they decrease each other's clearance. Talking about effects of propofol on central nervous system, It decreases CMRO2 by 50%, decreases cerebral blood flow, decreases ICP by 30%. Autoregulation, cerebral autoregulation is normal. It is not used in neurosurgery. This is relative contraindication because of decrease in systolic BP and decrease in cerebral perfusion pressure. We can use thiopentone or propofol in neuro patients depending upon the systolic BP of the patient. If we talk about cardiovascular system, there is decrease in systolic BP, which is more than thiopentone. There is inhibition of inotropic effect due to decreased calcium influx. Heart rate either not changes or decreases. There is decrease in systolic BP, stroke volume, cardiac output, MAP, afterload and preload. So overall cardiac if system, there is decrease in the parameters. So we have to keep in mind the state of the patient and we have to use the doses accordingly. We have to adjust the doses accordingly. Heart rate is normal because baroreceptor reflex, control of heart rate is depressed. There is increased incidence of oculocardiac reflex in propofol. There is no effect on SA node. The coronary perfusion pressure decreases and it leads to increased chances of MI. So it is avoided in patients with MI. If we talk about respiratory system, it acts as a bronchodilator. It blunts airway response to hypercarbia and hypoxia. So the patient will lead to respiratory depression when due to there will be no respiration in hypercarbia or hypoxia. So there will be depression of ventilation. There is decrease in tidal volume, decrease in respiratory rate. Hypoxic pulmonary vasoconstriction is potentiated. Propofol blunts hemodynamic response to LMA. Suppose we have to put a PLMA or I-gel. Propofol perfectly blunts the hemodynamic response to LMA, but for intubation the response is not blunted. If we talk about effects on eye, there is decrease in intraocular pressure. There is increased chances of oculocardiac reflex, especially in pediatric patients posted for squint surgery. Other effects are due to excretion of phenol, patient may present with green urine, usually seen with prolonged infusions, and due to uric acid crystals, cloudy urine can be seen. Toxicity is propofol infusion syndrome. We have discussed it. Then distribution is highly lipid soluble. Propofol is highly lipid soluble. Volume of distribution is 2 to 10 liters per kg. Volume of distribution is decreased in elderly. Volume of distribution is decreased in elderly and it is increased in pediatric age group, which leads to increased dose in pediatric age group and decreased dose in elderly. Talking about metabolism, propofol in liver is oxidized to 1,4-diisopropyl quinol. Then propofol and 1,4-diisopropyl quinol both are conjugated with glucuronic acid, these things are formed which are water soluble. So these are propofol 1-glucuronide, quinol 1-glucuronide and quinol 4-glucuronide. All these are water soluble and excreted by kidneys. In liver, in the presence of cytochrome P450, it is converted to 4-hydroxypropofol, which has 1/3 of hypnotic activity of propofol. Then the glucuronide conjugates and sulfate conjugates are made and they are water soluble and excreted through kidney. Clearance of propofol is 20 to 30 ml per kg per minute. Clearance is more than 1.5 liters per minute, which is more than hepatic blood flow. So the hepatic blood flow is 1 to 1.2 liters per minute and the clearance is more than 1.5 liters per minute, which suggests that apart from liver, other organs are also participating in excretion of propofol. The other organs are lungs and kidneys. So 20 to 30% of propofol is excreted through lungs and 30% through kidneys. It can be given in patients with renal impairment, which is mild to moderate, and in patients with liver disease. Renal elimination is less than 0.02%. Elimination half-life is 4 to 7 hours, and the context sensitivity half-life of propofol is 40 minutes. If the infusion runs up to 8 hours, the context sensitivity half-life of propofol is 40 minutes. So this was all about propofol. Now we will be discussing ketamine in the same format. So talking about ketamine, ketamine is present as ketamine hydrochloride with a concentration of 50 mg per ml. It has a preservative, benzethonium chloride, in vials. Ampules are preservative free. Ketamine is a phencyclidine derivative. It has two isomers S and R. S is better. We have to just remember that S is better as compared to R. It is 3 to 4 times more potent, more analgesic effect is seen with S enantiomer, and it has less side effects. It has faster clearance. So S has many advantages over R. The pK of ketamine is 7.5 and only racemic mixture is available. So this is about class of drug. Then if we talk about uses, ketamine is used as an induction agent. It is used for maintenance of general anesthesia. Ketamine is used as an analgesic agent. It is used for sedation. It is used to supplement spinal or epidural. It is used in as in preemptive analgesia and for pain management, both in acute conditions and chronic pain. Ketamine is used. So, talking about mechanism of action of ketamine. Ketamine has two ways to act, direct and indirect. Direct effect is cardiac suppressant, which is not seen because indirect effect is dominated. Indirect effect is norepinephrine release. Then there is functional disorganization or dissociative anesthesia, which is seen in ketamine, which is it depresses some parts of the brain and stimulates some parts of the brain. It depresses thalamus and neocortex and stimulates limbic system, including hippocampus. It leads to a state known as dissociative anesthesia, where the patient thinks that he is separate from self or separate from body. The receptors on which ketamine acts is NMDA receptors, opioid monoaminergic receptors, and it is an NMDA antagonist. Just for the completion, there are many other drugs which also act on NMDA receptors. One is propofol, another is ketamine. The other drugs are, any guesses? Other drugs are magnesium sulfate, cocaine, nitrous oxide, ketamine, and propofol. After mechanism of action, talking about dosage, so there are various routes of administration of ketamine. So there are various doses. So we are discussing here doses of two routes of administration, IV and IM. So for induction, we use 0.5 to 2 mg per kg IV. For IM, it is 4 to 6 mg per kg. If we talk about maintenance, the dose with nitrous oxide used as 50% with oxygen is 0.5 to 1 mg per kg. And if the nitrous oxide is increased to 50 to 70%, the dose is 15 to 45 micrograms per kg per minute. And if we are avoiding nitrous oxide, the dose is increased. It is 30 to 90 micrograms per kg per minute. If we talk about sedation dose, it is 0.2 to 0.8 milligram per kg IV in 2 to 3 minutes, and IM is 2 to 4 mg per kg IM. For preemptive analgesia, the dose is 0.15 to 0.25 mg per kg IV. So these are the doses. Talking about onset of action, ketamine has more than 1 hour brain circulation onset. It is approximately around 30 to 60 seconds. Duration of hypnosis is 10 to 15 minutes. And the various routes of administration are IV, IM, oral and intranasal. Talking about side effects, ketamine patients experience a cataleptic state. They experience undesirable emergence reactions such as unpleasant dreams, violence, aggressiveness, movement, sense of floating, which these all can be decreased by pre-medicating the patient with a benzodiazepine like midazolam 1 milligram. There is increased secretion seen while using ketamine. To avoid that, we use an anti-sialagogue glycopyrrolate before using ketamine. If we are using a ketamine infusion and if we stop that ketamine infusion due to S-norketamine, patient experiences hyperalgesia and allodynia. Dissociative anesthesia is also seen in patients and it is mostly seen in adults as compared to pediatrics and mostly seen in women as compared to men. Ketamine is used in hypovolemic patients. It is used in hemorrhagic shocks because it does not alter the cardiovascular system much. It can be used in sepsis and it is used in reactive airways because the ketamine does not affect respiratory system much and it can be used along with other agents in cardiac patient. Talking about contraindications of ketamine, ketamine is avoided in patients with raised ICP, with raised IOP, with open eye injury, in patients who have psychiatric disorders, in patients with liver disease and ischemic heart condition, and then it is not used as a sole agent in cardiac patients and in patients who have depleted catecholamine levels. It is avoided in patients who have depleted catecholamine levels. So neurosurgery patients who have raised ICP or in opthal patients who have raised IOP, open eye injury, we avoid using ketamine. The effects of ketamine on various systems in CNS, it causes a dissociative state, amnesia. The cerebral blood flow increases, ICP rises, there is increased CMRO2. That is why it is avoided in neurosurgery patients. Then it inhibits nociceptive central hypersensitization and attenuates acute tolerance of opiates. So it changes the tolerance of opiates. It inhibits nociceptive central hypersensitization. It increases cerebral blood flow, ICP. That is why it is not used in neurosurgery patients and we have not seen ketamine in neuro OTs mostly. Then, as we have discussed in mechanism of action, that ketamine has two effects, direct and indirect effect. Direct was cardiac depressant effect and indirect was release of norepinephrine, that is activating sympathetic system. So the dominant effect is of indirect and mostly the indirect effect is dominates and is seen. So BP, heart rate and cardiac output increases due to ketamine. So that is why it can be used in hypovolemic patients or hemorrhagic patients. Benzodiazepines also attenuate the hemodynamic response. If we talk about myocardial oxygen demand, it is increased due to ketamine. Talking about respiratory system, ketamine has bronchodilator effect. The response to hypercarbia is not altered. What is most important is airway reflexes are maintained, so it is used in patients with reactive airways, but we have to remember that it is not completely protective. We should not use high doses. If we talk about changes in eye, nystagmus is seen. There is increased intraocular pressure, not to be used in patients with glaucoma. Diplopia can be seen, blepharospasm can be seen in patients. using ketamine. There is increased salivation, lacrimation. We can use an anti-sialogo-glycopyrrolate before giving ketamine. There is increased muscle tone and it potentiates neuromuscular blockers. Talking about distribution, ketamine is highly lipid soluble. Volume of distribution is 3.1 liters per kg. Protein binding is 12%. Bioavailability of various routes is IV is 93%, oral is 20 to 30%, intranasal is 40 to 50%. Talking about metabolism, in the liver, due to N-demethylation, ketamine is converted to norketamine, which is hydroxylated to hydroxynorketamine. It forms water-soluble glucuronide conjugates and is excreted through urine. Ketamine causes acceleration of its own metabolism by enzyme induction, leading to tolerance. Clearance of ketamine is 12 to 17 ml per kg per minute, which is equal to hepatic blood flow. Ketamine is excreted via kidneys after glucuronide conjugation. It is avoided in liver diseases because it decreases clearance. Elimination half-life of ketamine is 2.5 to 2.8 hours. This was all about ketamine and propofol in a formatted way so that you can compare and contrast both the drugs and remember them. If you like the video, please like and share it with your colleagues. For any suggestions, please write down on comments. Thank you.